Good evening, everyone. Welcome to our first education session of 2026. This is a collaborative education session with Vanderbilt Behavioral Health in NAMI Davidson County. For those of you who don't know, I'm Don Liacono. I'm the Chief Program Officer here at NAMI Davidson County. And I want to welcome both Jon Coomer and Tracy Glasgow from Vanderbilt. Jon will be doing our presentation talking about psychiatric medications tonight, but I'm going to let Tracy introduce herself and talk a little bit about Vanderbilt and then pass it off to Jon.
Okay. Hey, good evening, everybody. I'm Tracy Glasgow, and I'm with Vanderbilt Behavioral Health, and I'm in an outreach role. And I love my job, and I love working at Vanderbilt. And I'm with the psychiatric hospital. And for those of you that don't know, we provide acute inpatient care for children, adolescents, and adults, and geriatric patients as well. So really a whole array of ages. And we also have some partial programs and IOP programs, partial for adolescents and adults. And then we have some intensive outpatient programs. One is for has co-occurring disorders, and another is just for general mental health. And we really work with a wide array of diagnosis and challenges. And we are so excited to be here tonight. We have a long-standing history with NAMI Davidson and partnering in many ways. And this is one of the ways that we like to support NAMI Davidson by providing speakers and being part of their educational outreach. So we are really happy to be here. And I am going to turn it over to Jon Coomer, who is a psychiatric nurse practitioner at Vanderbilt, and let him introduce yourself and tell you a little bit about himself, and he'll start the presentation.
Yeah, thanks, Tracy. Yes, thank you. Welcome to everyone. So happy to be here and to talk about medications. I'll try to keep it as upbeat and lively as we can. And so a little bit about me. I'm, like Tracy said, I'm a psychiatric nurse practitioner, graduated from the Vanderbilt program in 2013. So this is my 13th year. I have an administrative role at the psychiatric hospital at Vanderbilt in the outpatient side. That's kind of the dull part of my job, but then I also do outpatient geriatric behavioral health. So that's my outpatient clientele, and that's kind of my area of focus is geriatric psychiatry. But then our psychiatric assessment services, I don't know if you're familiar with that. It's kind of our walk-in, kind of like a psychiatric emergency department. It's more like a crisis kind of an evaluation type setting. So I work there a couple times a month regularly, and then also sometimes on the weekend. And so that's a very interesting dynamic place where you can kind of see a lot of different people and really help out a lot of people. So that's a little bit about me. I'm going to go ahead and share my screen. And while I'm doing that, I can't, while I'm doing my presentation, I can't see any of you all. So like Don was saying, put questions in the chat, and then we will have time at the end to talk about any questions or anything you may have. Okay. Let me see if I can do this. Okay. Can everyone see that? Somebody unmute and tell me.
We can see it.
Yeah, Jon, I can see it fine. Thank you.
Thanks. Well, I just kind of wanted to start off. Here's the topic. This is a presentation that I did for mainly nurses and other people in the medical field. But I'm going to, there's some jargon and some terminology in here, but I'll do my best to kind of really just talk about it in layman's terms as much as possible. So this is, again, the focus. We're going to talk about kind of psychopharmacology and kind of start from way back, probably 40s, 50s, and then kind of work our way toward now, breaking it out by kind of depression medications and anxiety medications, and then mood stabilizers for bipolar and other conditions, and then antipsychotics in that class. So that's kind of the outline and kind of the flow that we'll go to tonight. So with the depression, like the early treatments, and this is probably probably more close to in the 50s. We have, I think probably a lot of people have heard of the MAOIs. Well, this is what that stands for, the monoamine oxidase inhibitors. So it's always a mouthful. So those were the first antidepressants. Nardil, Parnate were a couple of the trade names of that people probably know or have heard. And you still see a few of these out there. The thing about them, they work by kind of breaking down it's an enzyme that breaks down those serotonin, dopamine, norepinephrine, and epinephrine. But the thing about it is the tyramine is also kind of like a cousin to serotonin, dopamine, and those neurotransmitters. So you can quickly get kind of toxic from these medications, and that's what you have to really be careful with the dietary restrictions for the foods that are high in tyramine, the aged cheeses, the cured meats, things like that, because that can really kind of increase the potential for those to be toxic. And then that last one, that no one's heard of it because it's been off the U.S. market for quite a while. After the MAOIs, we kind of started seeing the development of the tricyclic antidepressants, imipramine, nortriptyline, amitriptyline. Those are good for depression. They kind of work on that norepinephrine and the serotonin systems. This is where they started. The medication started to focus more on those two, the norepinephrine and the serotonin, kind of leading up to where we are today. The problem is these antidepressants work on kind of all of those serotonin receptors, which is reason and I'll get into this in just a bit, but this is kind of the reason that these type of medications have more side effects because they're sedating, they have a lot of gastrointestinal, like really upset stomach, the dizziness, the kind of the memory impairment. It's just because the way it works, it's just kind of a blanket medication that kind of hits all of those neurotransmitters and those signals. Today we see them a lot. People still use them. Migraine headache issues, amitriptyline can be good for that. Chronic pain. Some people still use them for sleep because they are so sedating. But for the geriatric population, there's a thing called the Beers list. It's down at my last bullet point there. If you've heard of that, it's kind of a list of medications that are not recommended for people, 60 plus, just because of all these side effects. You think about the geriatric population, you do not want to increase their risk for dizziness or memory impairment because falls and memory are things that we're always concerned about anyway. So we try not to use these in the older adult population, but people do still use them because they do work. They're a good antidepressant. Just the side effect profile is just a little bit, quite a bit more than most. And then kind of moving into the 60s, 70s, probably 70s, kind of that Prozac, Prozac Nation. It kind of the SSRIs, and this is what that stands for, that selective serotonin reuptake inhibitors. So as you can see, the medications are getting more and more targeted and specialized, whereas we started out with the MAOIs, we're kind of hit kind of everything, and then the tricyclics did the same thing as well. So now we're looking at really honing in the pharmacology of those specific receptors in depression and anxiety, which we'll talk about in a minute. So fluoxetine or Prozac was the first SSRI approved in 1987. And then in the same class, the SSRIs are citalopram. And then I've got the trade name there in parentheses. Sertraline, Zoloft, escitalopram, Lexapro, and paroxetine, Paxil. So I think a lot of the general public who have never even had to take medications probably would recognize these because they're very common. They're overall very safe, and they're used pretty widely. And the way they work is they increase that concentration of serotonin in the brain, whereas there's with depression there can be, I like to talk about like Pac-Man, like the serotonin's floating out there in between the brain signals, and that's what our brain needs that to function normally, and it's for the mood and concentration and many other things. And depression kind of like acts like that Pac-Man and kind of just snatches it up, and so it's not available. So the SSRIs just kind of prevent that reuptake of those eating, if you will, of the serotonin and the norepinephrine and other things. But like with all medications, there are side effects from these, and the most are reported are nausea, insomnia, and then sexual dysfunction is unfortunately kind of common. Most side effects with our medications, hopefully will resolve after 1 to 2 weeks. We try to encourage patients to, if they can get through side effects, to try to wait it out, because often the side effects are on the front end of starting treatment, and usually will subside. And then, so to just more some of the atypical antidepressants, and again, most people I think have heard of bupropion or Wellbutrin, late 80s, and it was the first really one that was widely known to work on that dopamine system as well. And so dopamine in our brain is responsible for that kind of that drive, the motivation piece. So if people who are like profoundly depressed and just like really can't get out of bed and just get motivated, and concentration and memory and things like that, and just that lethargy, Wellbutrin can be a really good either by itself or an add-on to some of the other medications. But again, with all medications, there are side effects. Wellbutrin is kind of known for dry mouth, insomnia. Most people take it in the morning. It comes in a 12-hour and a 24-hour kind of release. Most people take the XL 24-hour release. If you've had any seizure issues in the past, or even a risk of seizure, we don't use Wellbutrin because it kind of lowers that seizure threshold and puts you at higher risk. It does have less sexual dysfunction than the other antidepressants, so sometimes we use this one if people have a low libido or can't, have a lot of sexual dysfunction side effects. So we can use this one, Wellbutrin, to kind of offset that. And it is used for smoking cessation. It's kind of how that dopamine system works as well. So it does help people stop smoking. So, kind of win-win for a lot of people. Some other, the kind of atypical, I've listed them as atypical, but they're just in kind of their own class by itself. Mirtazapine or Remeron. A lot of people, it's kind of an older one, works more on that serotonin norepinephrine system, but it is very sedating at lower doses. So like 7.5 milligrams at bedtime, very, very sedating, and can you help with appetite stimulation. So if people are losing weight and not sleeping, it's a really good one for that. I use it a lot in the geriatric population, just because weight loss as we get older is typically a very negative thing, because our muscle wasting and just that failure to thrive. So I use mirtazapine quite a bit, and it can be added to other antidepressants as well. And a little fun fact, I think, is that it's kind of got this nickname that I never really heard until just 4 or 5 years ago, about California rocket fuel. Apparently, if you put Remeron with Effexor, it really can give people a lot of more energy, and in a positive way, not like an amphetamine way, but just kind of like a really good booster. So, we're continuing this. I say we, I'm not doing any of the trials, but science is continuing to come up with new and improved medications, primarily more of a targeted approach. So the SNRIs, the serotonin norepinephrine reuptake inhibitors, whereas before it was just the SSRIs, just serotonin. So now we're looking at both the serotonin and the norepinephrine, like preventing both of those from getting eaten by the depression Pac-Man. Then Venlafaxine Effexor, that was kind of the first one. A lot of people have tried it. It works great for a lot of people. Very difficult to get off of sometimes, and if you're for switching because of and we can talk about this later if you want. A lot of people have the zaps, the brain zaps. Not quite sure when tapering or stopping this one. A lot of people experience that. And that we can offset that by just really being very slow if we're having to change that one to, taking 2-3 months sometimes to lower and get off the Effexor. Duloxetine or Cymbalta, same class, works basically about the same thing as Effexor. It works really well. Can be also kinds of an added treatment for chronic pain, diabetic neuropathy pain, also for the antidepressant and anxiety issues as well. Talked about kind of the mechanism of action. They're not as sedating because of the histamine, that last bullet point, the histamine. That's the neural pathways and neurotransmitters of the brain that really are the reason why a lot of our medications are sedating. Think about Benadryl. Benadryl works in that histamine system, and that's why when you take a Benadryl, it can really make you tired. The Effexor and the Cymbaltas of the world, they don't really have much impact on that. So again, as the science progresses, the goal at least is to have fewer and fewer side effects from our medications and then better response. Bordiexatine or Trintellix, one of the new kids on the block, 2013. And where I'm talking about those specific serotonin receptors, this is just a snapshot of what this one works on. So serotonin, there's 5-HT1A and 5-HT1B and 3A. They all have their own kind of what they're responsible for. And so by targeting those specific, those receptors like down to that level, the goal is to have an effect, but then have less of that blanket coverage and side effect where it's hitting kind of all those receptors, causing the weight gain and the tiredness and all that. Whereas this one is really just focusing on those specific ones and the symptoms that those receptors kind of are involved with. Like I was saying, limited weight gain and sexual dysfunction on this one. It's unfortunately still, I think, kind of expensive, and hopefully it will go generic soon. So I don't use it quite that often just because of that, unfortunately. But it does work on people who can have good insurance or can get through a patient assistance program. It can really help. And then kind of the next phase of where we are is in the glutamate system. And glutamate is the major excitatory neurotransmitters in our brain. And so here's where we're starting to look at the NMDA, and ketamine and things like that, which we'll get to just in a second. So there's there's information out there, but the research is still evolving. And so ketamine really can work for a lot of people, and but it's really it's not controversial anymore, but it's interesting how it's proposed to work. And like I said, here's that's ketamine. It's the nasal version of ketamine, and it is FDA approved now for treatment-resistant depression. So like for people who have tried all the medications or several of the ones we've talked about, TMS, ECT, all electroconvulsive therapy, basically all the treatment modalities, and still are just having profound depression, ketamine can really help. And then also the acute suicidal thoughts with major depression, it's been shown to have been beneficial for that. And I'm not going to try to be the expert because I'm not primarily, but to kind of explain how ketamine works. But it does work on that glutamate receptor, kind of blocks it. And it kind of, the thought is it kind of increases this glutamate in the brain, which is the most abundant chemical messenger that we have, and kind of helps connect and repair some of those neural pathways. There is some research out there that talks about kind of that restructuring of brain of like past traumas that can impact depression, and kind of how our brain learns to live in that depressive environment. So with that glutamate surge, that's the theory. But then again, every medication has side effects. So ketamine used to be, and it, I guess still is, it's kind of one of the club drugs, because it is like a dissociative hallucinogen if used improperly. So administering, giving this one, of course, it's in a controlled environment in a clinic. You can have people have hallucinations and then have that dissociative, kind of that floating feeling of kind of that outer body experience. I don't want to go into this too much, but the Spravato, it's a nasal spray, and here's the dosing. And again, you all have I've sent Don the copy of my PowerPoint today, so it'll be available if you're interested to look into that, because it's talks about the schedule of the medications. And so moving from depression to more of the anxiety treatments, again, it's our serotonin system that's responsible for anxiety. That 5-HT, that's the medical term for the serotonin system, and it's really been long implicated in the treatment of anxiety. SSRIs are our first thing that we'll try. If no one's ever, if somebody comes in having anxiety and they've never tried any medication, we'll talk about one of the antidepressants that help with anxiety. Fluoxetine or Prozac, again, was the first medication approved for GAD, general anxiety disorder, in 1999. And then buspirone, it's a medication that just partially blocks that 5-HT1A receptor, that serotonin receptor. So Buspar is kind of the first alternative to the benzodiazepine class for anxiety. And then off-label medication, off-label uses that we use, propranolol, which is a beta blocker that we use for high blood pressure, but at lower doses can really help those physical symptoms of anxiety, the dry mouth, the sweatiness, the kind of those panic type symptoms that people can have with anxiety. And then hydroxyzine, which is kind of like a big brother to Benadryl, works on the histamine system as well. So those two we use kind of instead of the benzodiazepine class, the Valium, Klonopin, Xanax, all that. If patients don't absolutely have to have them, especially in the geriatric population, because of the falls. So here's the benzodiazepine class. I think most people have heard or taken or seen, talk to people who have taken these. And I'm not an anti-benzodiazepine person, because they really do work. They're effective. They work on that the GABA system, which is that major kind of the calming neurotransmitter of the nervous system, and they kind of really they can really help with anxiety symptoms pretty fast. Valium, diazepam was one of the first ones. I mean, there's some older ones than this, but Valium's pretty well known, been around for a long time. And when I say long half-life, if you're not familiar, that means how long it stays in the body. And so Valium really stays in their body a long time. So that's why people feel that they have a lot of next day kind of that hangover-y feeling, because it's kind of just lingering in our system. Lorazepam or Ativan, shorter half-life than Valium. Pretty potent though. That's what we use in emergency situations. So Ativan, and it's one of the ones that comes in an injectable. So if you're like having a seizure, or you can use this to stop it. And then alprazolam or Xanax, very short half-life, and that's why it's used primarily for those acute panic attacks, because it gets in your system, it works fast, and it's out of our system very quickly as well. But with that is why I feel like it's probably abused more than others, because it works so great, and then your body's like, wait, where is that? Where's that feeling? I need more. And then that's how it kind of can kind of snowball for some, not all, but for some people. And then cannabinoids, marijuana. We've all, I'm sure, seen and talked about and possibly tried. And again, I tell my patients when asked about this, it's not legal in Tennessee, so I can't legally say yes, do it. But if they've tried it and it helped with their anxiety or it helped with appetite, chronic pain. I mean, there's lots of things that CBD is being used for, and I look at it as a personal decision or for the patient, and I am there just to offer any guidance. I don't weigh in on it because legally I cannot, but if they've tried it and it helped them, I usually just look at them and say, I think you have your answer. So, some people do use this for anxiety and PTSD and different things. And again, to each his own, or their own. So that's my take on that. So for kind of moving into the bipolar disorder realms, the bipolar is really, those states of severe ups and downs, and sometimes milder mood swings, and poor sleep, and just riskier behavior, and just a lot of that instability. And bipolar can be really hard to treat, all the variations, because there's bipolar 1 and 2, and I think there's now even more than that. So there's a lot of ways bipolar can present in folks. But so the class of medications that we use are mood stabilizers. Those really are kind of the first line treatment. Lithium has been around for a long time. It's actually just a salt product, and that's why we'll talk about the lab work in a minute. It was first treatment for that acute mania. It works great, but it can be really serious, and if you could get too much in your system, then you can get toxic, and it actually can be very serious. Depakote, valproic acid, it's another name for that one. It's an anti-seizure, the anticonvulsant piece. That's anti-seizure. It kind of works on that GABA system, which kind of going back to that relaxing pathway for the anxiety. So that's how Depakote works. Tegretol, Topamax, kind of same in that same class. It kind of really works on the sodium channels in our system that are causing kind of that lightning storm, if you will, in our brain. Whereas, so these medications really just kind of help kind of slow those firings down in our brain. And so in the 60s, it was used for trigeminal neuralgia treatment, which is that severe facial pain. I'm not going to quiz you all on these questions again. This was a presentation for a group of nurses. But if you know the answer to this, we'll talk at the chat. So lithium, back to it. It really was that first treatment. It works well. Can be used to kind of reduce the risk of that chronic suicidality. If people just really have struggle with that, lithium can really help. It's got a real big family response. If somebody in your family has bipolar disorder and they did well on lithium, chances are you can do well on lithium. Talking about that really narrow therapeutic dose. So if you're on lithium, you are going to get your labs drawn pretty regularly on the start of treatment, probably every few months. If there's any changes of dosages, we're going to draw, get your labs done as well. Because if we go toxic on that, if our body starts to take too much of it up, it can really cause a lot of problems. And when I mentioned it was a salt, it's a derivative of a salt product. So like if you're out in the summer and you're on lithium and you're sweating a lot and you're outside and in your body, for your body will start taking the lithium that's in our system and pulling it into the bloodstream to try to counterbalance that. So that's how you can become toxic pretty quickly with lithium. It works well, very safe. I got a ton of people on it, but it's just one of those things that we have to watch. And it does work for those. It's shown to work for more of those bipolar 1, those pretty significant mood shifts. It seems to, as far as the mood stabilization piece. We don't really just stop lithium. It's one of those that we really cannot taper down because of the risk of relapse. And then, I won't go much into that. And as far as this goes, I mean, I'm not going to go into specific, but lithium is a really good mood stabilizer and can be used in conjunction with other medications for other mood symptoms. Valproic acid, or the Depakote, again works on that GABA system. It's also a seizure medication. Works in the dopamine system. It's metabolized in the liver. So if you have liver issues or any cirrhosis or fatty liver disorder, anything like that, Depakote is probably not a good choice because it can cause a lot of issues with our livers just not working the way it should. Not recommended for women of childbearing age because of this pretty high significance of spina bifida. If you're taking Depakote and become pregnant, you can continue it. Spina bifida is a major risk factor. Also, another therapeutic range. It's pretty. It's not as narrow as lithium, but it's there. And low is not a problem. It just means it's not going to provide you seizure coverage. High, it starts to build up in our body and cause more confusion and difficulty with ataxia. Means just balance issues. Alopecia, just some different things that you can experience from that one. One of the newer agents of the mood stabilizing class, lamotrigine or Lamictal, really, really good medication. Works in the calcium and sodium channels in the brain. Kind of inhibits that glutamate, so that helps with that mood fluctuations and that electrical storm of the brain, if you will. And we start it very slowly and go up on it slow. And the reason is going to be on the next slide, because if you've been on Lamictal, I'm hoping that a provider talked about the severe serious risk of Stevens-Johnson syndrome. Here are pictures of it. It's this very significant, life-threatening, potentially toxic rash that can happen from not just Lamictal, but there are several medications that this can, is a possible side effect. But Lamictal is one of the ones that we really kind of watch this one for, and then do a lot of education on parents. It's a lot of the mucosal lining is where you'll see the rash that can start, and the chest area. I've seen it one time in my 13 years, but it is go to the hospital, go right now, stop the medication because you're going to need some supportive treatments, IVs and things, because it can be very serious up to and leading to death. So it's one of those that we do a lot of education on about. Start it, do it slowly. If you miss 2 weeks in a row, you got to kind of start back over at the lowest dose and kind of build your way up because of this risk. And then our last class, it's the antipsychotic class for mood stabilization, and then we'll talk about the psychosis aspect just in a sec. But here are the list of the FDA approved, the atypical antipsychotics. The first class were the typicals, the first generation, the Haldols, Thorazines, all those. They, again, kind of similar to the depression medications. The oldies work great, but they a lot of side effects, weight gain, tardive dyskinesia. These still have those same potential side effects, but much less than the originals. The olanzapine, Zyprexa, Risperdal, Seroquel, Abilify, Geodon. Those are ones that a lot of people probably have heard of. They work really well for mood stabilization, and then also for treatment-resistant depression, particularly Abilify and a couple of the others. The antipsychotics, they kind of work on that dopamine system, kind of for decreasing the mania. Also in the serotonin system, that 5-HT2A. There you go again. There's another one of those specific serotonin that kind of helps with those affective, which means like the depressive, kind of those features of mania. Zyprexa, Risperdal, Abilify, and Geodon, we find are better kind of for that mania and those mixed episodes where you have depression and some mania. Seroquel, probably more for the mania at higher doses. But Zyprexa and these, mainly Zyprexa, Risperdal, and Seroquel, weight gain, huge component of those. Geodon, not so much, but it can happen. It's a lot of counseling when we start patients on these medications of, if you start gaining weight, we'll discuss options because that's one of the big unfortunate side effects from it. Saffras, one of the newer ones, kind of thought to be better for controlling the aggression with some of the psychosis, schizophrenia, bipolar issues, but again, kind of one of the newer ones. Think it's a little more affordable now, but it's still one of the newer ones that it's a little more expensive. If you own a TV and have network television, you've seen commercials for all of these. I'm sure a lot of these are the new ones. Vraylar, in that antipsychotic class, but also for bipolar disorder, treatment-resistant depression, working with the dopamine and the specific serotonin receptors as well. Most of the antipsychotic and the mood stabilizer class, not most, but several have issues that can affect the heart, that QTC prolongation there. It's just something that we will want to get a EKG just to make sure that the heart's beating the way it should. Side effects, kind of the non-adherence part of this. It's unfortunately, a lot of folks with bipolar and other, variations of that will feel better on medications, and then, not necessarily. I've talked to people who are like, I like it when I'm up. I feel great, and the medicine makes me feel heavy, and so I'm not manic, but I just don't feel like I want to. So they'll unfortunately will stop, and some people do well, but then a lot of times people will, have kind of a relapse and of the not so great part of mania. The side effects from these medicines, kind of like I said, the weight gain, the extrapyramidal symptoms, the freezing, the tardive dyskinesia, there's just a lot of potential side effects from these. And then kind of, all of not all, but a lot of the antipsychotic class come in long-acting injections, monthly, some even couple 3 months. You just need a shot like 4 times a year. That just gives you that sustained release of this class of medications. This primarily is used for folks who, just aren't as compliant or adherent to medications and will stop, and lots of relapses. So have a lot of people on these, and it's convenient for a lot, and it keeps people kind of well and out of the hospital. These are very, very expensive, but insurance does cover them. So I think, just to give you a perspective, the Aristata, the every 4 to 8 weeks, I want to say that's about a $6,000 injection, but insurance will cover it. So that we're very fortunate at Vanderbilt to kind of work with insurance companies and our pharmacy to get medicines like that covered, because quite frankly, no one can afford that much money. I should say very few people could. And that's it. Those are my references, and I'm going to stop sharing, and we will entertain questions. I hope everyone is still awake, because I know some of that can be a little dry, so I do apologize.
I appreciate it, Jon. We do have one question already in the chat. So
Mhm.
how does a depressed person know if the med is working or should try another? So
Good question.
what
I
should
mean,
they expect?
we always try to counsel people to be like, for let's just say a standard antidepressant, 4 weeks. Give me 4 to 6 weeks. Just let's just see how you do. To make sure you're not going to have side effects, and then just kind of getting your body used to it. And if you're tolerating it, hopefully you're gonna, for whatever that kind of brought you to me, saying like, I can't get out of bed, or I'm just feeling down all the time. Hopefully, either you notice it or the people around you will notice it. Because, I talk to a lot of families and be like, I don't, the patient will say, I don't know if I'm better. And the family member will say, you're better. I see it. You're out more. You're getting up. You took a shower this week, because a lot of people with depression sometimes they just can't get out of bed for what, and it's not always just that, but it can be, hopefully the patient will see and feel better, but then people around them hopefully will notice and share that with them. But it does sometimes take a week, month to plus before it can help.
And I will ask this as a follow-up. What should you do if you want to go off of medication? If you don't think it's working, or for myself, years ago, side effects were the main reason I would go off of medication. I did not like the side effects, especially the sexual ones. I'm going to be
Right.
honest.
And I talked to a lot of people, and I can say till I'm blue in the face, oh, I really wish you would do X, Y, and Z, but you're going to go home and do what you're going to do. So if it's not working for you, I mean, you know your body, and so having that good conversation with your provider, saying, hey, I'm having this side effect. I would really like to talk about options. If it's the first couple of weeks of treatment, that first month, I would probably be like, hey, can we just can you do a little long? Can we do a little bit of more, time? Just give it a little more time. But if it's been a couple of months, 3, 4, 5 months or whatever, you're like, all right, it's probably not going to get better. And so we'll have a discussion about, options. And if you wanted to try, if a patient says, I'm ready to come off of this medication, I'm like, okay, let's just reduce it and come up with a plan and see how you do. And because I really feel like it's the patient's decision. Your bodies and how you feel. So yeah, that's my outlook on it.
Okay, and I will ask this because many of us, including myself, I'm not pointing fingers. I'll point at myself. Is it ever a good idea to go cold turkey?
No, not on anything. You're gonna have. I mean, there's withdrawal effects from most of our medications. Paxil, if you've ever taken Paxil or know anybody that's ever taken Paxil and stopped it, you're gonna feel like crap for a good long while. And so slowly, if you're gonna do something, slowly, 10 to 20% reduction over a week, if you can, and keep going down.
Makes sense. We have a follow-up. Is there any way to speed up the trial and error process?
No, I mean, to me, with side effects is, if you've had a bad experience with one class of medication, and I would be very conservative as a provider and be like, all right, let's start with 25 milligrams of Zoloft instead of 50. Let's just, do that for a couple of weeks, just to really give our bodies time to adjust. Because most of the side effects is our body's just saying, wait a minute, what is that? What's in my body? And it's just kind of your receptors in your brain. I didn't mention this, but the majority of our serotonin receptors in our body, for everybody, are in our gut, are in our stomach. So that's why we have all those GI side effects from our medications, because a lot of that's rumbling down in there. So if you can just kind of slowly give your body time, sometimes you can offset it. The Wellbutrin added for the sexual side effects, that sometimes can help. But there's nothing you can really take that's going to prevent side effects, really.
Thanks, John. Do we have any other questions?
Hey, John, it's Brad.
Mhm.
Really appreciate the insight. Super fascinating. I have two questions for you.
Mhm.
Number one's pretty specific. With regard to clonazepam,
Mhm.
are you of a mindset that you should take that regularly or kind of as needed? And the reason I ask is ironically, it's, I have anxiety and then I get anxiety about taking medication because, you go on and I self-medicate on the internet and it's like, oh my
Yeah.
gosh, you're on clonazepam, it can have long-term effects. Like, what, you know,
Right.
I, I try to stay regular, but then there are times where like, I feel pretty good. Like maybe I'll just take kind of as needed if my, well, I think you described it as it's not mania, but if my thoughts just kind of start running around, it's like I know it's kind of time to, hey, let's just relax a little bit here. Start overthinking things, right?
Yeah. The way I approach that is, now good. Let's just say, for hypothetical, if you're taking a half a milligram of Xanax twice a day and been doing that for a long time,
Right,
if you don't take that for a couple 3 days, you're going to feel it, because
right,
clonazepam does stay in your body a little longer, not as much as Valium. I use clonazepam quite a bit instead of the others because I think it's good.
right,
It can be taken as needed, but that's like, once you get to a point where you're not taking it every day, then, like, if say you fly and have anxiety around that, if
right,
you haven't taken it in in a month or so, take your clonazepam, take your flight, be fine. But if you're taking it regularly, I always encourage people, if you want to try to reduce it a little bit, cut up one of the doses in half, just
right,
and give yourself a good couple weeks on that one. And then if you're doing okay, cut the other one in half, and then give yourself time. And I always tell people too, it's never a problem if you have to go back up on it. People
right.
do it all the time. They're like,
Makes
life
sense.
happens, and you're like, oh God, I'm having a stressful, time, and there's no harm or foul in, like, all right, I'm gonna have to go back up on a little bit. It's a it's a process, and there's no right answer for everybody, but just I always tell people, give yourself a break. Like, look, it took us a long time to get here. We're not going to solve
Right.
everything in one time. So, but yeah, clonazepam, if you've been taking it regularly and you don't for a little while,
Okay.
you'll feel
Gotcha.
it.
Okay. Appreciate that. My second question, and I don't want to be controversial here, but you talked about THC and
Mhm.
ketamine.
Yeah.
I've recently read some Michael Pollan, and
Mhm.
specifically that How to Change Your Mind. I
Mhm.
was just curious, and again, in a controlled environment like LSD, mushrooms,
Mhm.
ayahuasca,
Yeah.
again, controlled environment.
Yeah.
The research and things that he puts forward, and it seems pretty compelling. I just was curious, like, what are your thoughts on that? I mean, it's seems like there's something there.
Think there is something there, and I am in no way an expert, and but I know who you're talking about and read some of this stuff, and I think it can be, in a controlled environment, very helpful for the person. So I don't think I know enough to kind
Okay.
of give my thoughts. I'm not anti any. I hope
Right,
I didn't
right.
come across as that for THC or ketamine,
Not
because
at
I
all.
really feel like it's the personal decision on what treatments that they want to explore. But I would know who you're getting it from,
Right.
and the source, and because
Right.
I think we're starting to see a lot more of a lot of people are kind of dabbling in it now, and I really do hope that it is a watershed moment for mental illness and can kind of help open the door on some things because there's just so much we don't know.
Right. Right.
Yeah,
Well, appreciate that. Thank you so much.
yeah, sure. Thanks for the question.
Definitely. Thanks for that, Brad. All right. Next question. What are your recommendations for balancing medication and non-medication treatments for mental health conditions?
I, it's so important. I think I tell people, okay, I treat geriatrics. So I have 60 and above, I have 106-year-olds. So that's my range. So my take is like get outside, do something if you can, touch some grass. I think that physical aspect, eating good balanced diet, don't restrict, eat what you want, but balanced, get some good sleep, try to, meditate, whatever you can do to kind of quiet that mind. And because our mind body it's connected. I mean, it sounds cliche, but it is, we're it. And so taking care of yourself, that balance is super important. And, right now, I'm not going to get political, but I mean, I have a ton of people are just saying, I can't watch TV anymore. I'm like, turn it off. you know, you don't, don't get so wrapped up in it. Anyway, easy to say, but medications are not the answer to everything. I mean, it can help. Counseling by far is helpful and with medication, but that mind body, checking in with ourselves, getting outside, doing whatever you like to do, read, knit, play with your cat, play with your ferret. I don't, something. Just take care of yourself. That's really important.
Thanks for that. And I will add that, and I mentioned this in our groups and when I teach classes, my walks that I
Mhm.
take are if I not walking leads to deeper depression, and truly
Mhm.
walking keeps me from my suicidal ideations.
Yeah.
Uh, and when I
Yeah.
talk myself out of those regular walks, I pay for it.
Right. And I tell people, especially older, much older folks, I'm like, do whatever you can. If like walking from the recliner to the refrigerator is exercise, then great. Then celebrate that. Just keep keep moving. Just kind of, and yeah, it's a struggle.
All right, next question is, what are the riskiest and the safest medications to use for someone who abuses drugs or alcohol?
Oh God. Ugh. Um, I mean, so I might need a little more clarifying information. So like maybe like for anxiety, let's just say, let me take that. Let's say somebody has alcohol issues in the past. I would not, um, I would not put them on a benzo like a Xanax or Valium long term, because it kind of works the same in the brain a little bit, kind of alcohol and the benzo class. So I think that's something that would really put somebody at risk for relapse, or taking that or combined with an opiate like a pain med. Um, Safest, I mean, the antidepressants are all pretty much safe for any substance use issue. Um, Saving the mood stabilizers. So yeah, I mean that's a pretty safe thing. I would just the biggest risk I think would be kind of setting someone up that would kind of potentially lead them to relapse with if you've got a stimulant use disorder like of amphetamine abuse history, then I wouldn't do Adderall or Vyvanse or any of those because I think that could um yeah. So
And
hope
it,
that answered it. That was kind of a
yeah,
general
yeah.
response.
And as someone myself who when they were medicated for their anxiety and depression was also drinking heavy, it usually doesn't work. It usually leads to more problems.
Yeah. Yeah.
When you mentioned Paxil, I was thinking my days on Paxil allowed me to drink like a fish, and boy, you did not want to know that, Don. Trust me.
Yeah.
And I joke about this, but it's true. I am not a pretty drunk, and I'm also a heckler. So you can, I know I'm the biggest jerk in the room. That's why I don't do it anymore. But again, I did mix, medication with drinking, and thought I was winning. Uh, and
But
back,
with that too, drinking and the benzo class and opiates, I mean, that has, I think we've seen that unfortunately take so many lives of celebrities and others, think of Heath Ledger or all, you can just think of you can go down the list, but the Valiums and drinking and throw in a Lortab, and you're going to stop breathing. And so definitely not that combo.
Another question is I'm going to rephrase this. What medication is affordable or and easy to get for people who have very limited resources?
The sertraline, the Zoloft, Prozac, Lexapro, all they should be $4 at the most at any pharmacy. I mean, the mood stabilizers, lithium, Seroquel, Depakote should be cheap. They all should be generic. The newer ones are the only one. The Vraylar, Rexulti. What are the new commercials? I mean, every time there's something new. But those, I think the last time I checked for a patient, because they'd seen the commercial and they asked me about it. And I said, well, let's talk about it. And I checked with our pharmacy, it was $800. I think it was Rexulti. It was $800 a month. I'm like, so can you afford that? They couldn't. I'm like, all right, so let's figure out something different. So yeah, but all the older ones, and again, they work. Cymbalta and Effexor, those are generic now. They should be very affordable. Yeah, it's just really the newer ones that are super expensive. Trintellix and there's that side note, real quick. Have you seen there's a combo that's Wellbutrin and is it Prozac? No, it's Wellbutrin and basically the same thing as Robitussin, dextromorphin, because that kind of helps get the Wellbutrin in our brains a little quicker. It's super expensive, and it's an old Wellbutrin's dirt cheap, should be, and then dextromorphin is Robitussin. So if you take Wellbutrin with Robitussin, it's gonna potentially do the same thing as this pill that's like $500 a month, which is anyway. I don't want to. I'll get off my soapbox about the.
Well, and I was going to say, with again, for those of you who will be watching the conference championships and the Super Bowl in the next few weeks, you'll see plenty of these commercials alongside alcohol commercials. But with
Yes.
And is there when we talk generic, John, does that just mean that it's been around long enough that they don't feel it's a moneymaker anymore, or why does something become generic?
I think the U.S. patent system, I think it's 10 years. Most drugs have and if anybody knows, please unmute and tell me. I think, the drug companies, they get a patent on something, and I think that lasts 10 years, and then there's a law that says then other companies can make the generic equivalent. So that's why.
Okay.
It's a monetary proprietary thing. And before I forget, I encourage my patients to talk to their pharmacist. Because the pharmacist can really work magic on getting things covered and putting prioritizations in and coming up with answers. So reach out to them. They really do want to help.
Thanks, John. Any other questions? Right. Well, that to me is always a sign that it was an informative session and you answered all the questions. So we do have some comments that this was a very interesting presentation, et cetera, and to thank you, John. But before we thank John for the last time tonight, I want to make a couple quick announcements. These ed sessions, we try to do them monthly. It depends on speaker availability, but we will be having our next one on February 18th. We do them on Wednesday evenings, usually the third or fourth Wednesday of a month. We have at the intersection between mental and physical health on the 18th with a representative from Centerstone. Couple things NAMI Davidson wide. We do have our Well Within Awards coming up on February 25th, Wednesday in Bellevue. We're recognizing people in the community who have been doing good work in mental health, including volunteers and organizations. And I always want to remind you, because Vanderbilt always has a very competitive team. We have our walk coming up. It's only but 3.5 months away, May 9th. We're doing it on the second Saturday this year due to a scheduling conflict because we are at First Horizon Park. So we will be doing it on May 9th, our annual NAMI Walks, Middle Tennessee. It's our biggest community awareness event and fundraiser. So you'll be seeing more of that in the newsletters you all get. Anyone who registers for programs gets the Monday and Wednesday newsletter. And I will say one more thing. We do have a family-to-family class starting in person in Southern Nashville, February 21st. We still have spots for that. That is for family members who are looking to learn more about how to support their loved ones who have mental health issues, including there'll be sessions on medication, etc. So with that, I want to thank Jon for taking his time tonight for a wonderful presentation. I want to thank Tracy and Vanderbilt for collaborating with NAMI Davidson for over a decade. I've appreciated it in my 5.5 years here, and I hope to continue this collaboration. So I want to thank Jon and everyone for being here and supporting our programs. So everyone, thank you and good night.
Thank you.